Welcome to this explainer on the gross anatomy of the thoracic mediastinum and heart. If you're a second-year medical, nursing, or health science student getting ready for your anatomy or physiology exams, you are absolutely in the right place. Think of this as your premium revision class. We're going to build a layer-by-layer understanding of this region, giving you the high-yield intelligence you need, not just to ace your exams, but to confidently apply it in real clinical practice.
To get there, we'll follow a clear roadmap. 1. Foundation, focusing on the mediastinal container. 2. The protective casing and clinical reality. 3. The internal pump, specifically chambers and septa. 4. The power supply, which is the coronary vasculature. And finally, 5. An end-of-lesson review to lock it all in.
All right, let's jump straight into Section 1, Foundation, the mediastinal container.
Before we can even talk about the heart as the self-adjusting pump, we really need to understand the box it sits inside, right? We call this central compartment of the thoracic cavity the mediastinum. It sits squarely between the two fluid-filled pulmonary cavities and rests directly on the diaphragm. Now, here is a crucial conceptual point that examiners absolutely love testing: mediastinal mobility. Because this area is packed with hollow, fluid-filled, or air-filled organs that are bound only by loose connective tissue and fat, it's actually highly mobile. Gravity and patient positioning, like whether your patient is standing up or lying flat on their back, will significantly shift exactly where these internal structures sit.
Understanding how this space is divided is absolutely key. We have superior and inferior compartments, but I want you to pay very close attention to the transverse thoracic plane. It runs anteriorly from the sternal angle, which you might also know as the angle of Louis, straight across to the intervertebral disc between T4 and T5 posteriorly. Why is this so important? Because this specific imaginary plane perfectly divides the superior and inferior mediastinum. Definitely memorize this anatomical landmark. It's a guaranteed multiple-choice question.
Moving right along to Section 2, the protective casing and clinical reality.
As we move inward from those boundaries, we hit the protective casing of the heart. The heart is completely enclosed in a double-layered fibrous sac called the pericardium. Let's break those layers down. The outermost layer is the fibrous pericardium, which is incredibly tough, dense, and, this is crucial, inelastic. It just doesn't stretch. Inside that is the serous pericardium, which actually folds into two layers of its own, the parietal layer lining the fibrous sac and the visceral layer, or epicardium, resting right on the heart muscle. Between those two serous layers sits the pericardial cavity. This space is lined with flattened mesothelial cells that secrete a thin, lubricating fluid, which totally prevents friction as the heart violently expands and contracts.
So remember how I said that outer fibrous layer is inelastic? What happens if fluid rapidly builds up inside it? Well, this exact sequence outlines the pathophysiology of cardiac tamponade. It's a massive, high-yield exam and clinical topic. If you get inflammatory capillary leakage or a post-infarction rupture, fluid or blood rapidly accumulates. Because the outer sac can't stretch to accommodate it, all that fluid creates intense pressure inward, crushing the thin-walled right atrium and right ventricle. This massively restricts ventricular diastolic filling. Stroke volume drops off a cliff, cardiac output collapses, and blood just backs up into the superior vena cava. That's what leads to systemic venous engorgement, which you'll literally see in a patient's neck and face as part of Beck's triad. I love this simple but brilliant analogy because it makes the biophysics so crystal clear. Imagine putting a borehole pump inside a tight metal cage. If you fill that cage with mud, the pump just can't expand to draw water up. The taps in the house run dry. In cardiac tamponade, the blood is the mud, the fibrous pericardium is the rigid metal cage, and the heart is the pump. Thinking of it this way conceptually anchors exactly why mechanical decompression, physically draining the fluid, is immediately necessary to save your patient's life.
But how do you actually mechanically decompress that sac without accidentally puncturing a lung? You use what's called the bare area of the pericardium. The cardiac notch in the left lung creates this perfect little window where a segment of the pericardium is directly exposed. Always remember this for emergency interventions. It allows a wide-bore needle to be safely inserted straight through the left fifth or sixth intercostal space right near the sternum.
Okay, let's head into Section 3, the internal pump, chambers and septa.
Having established the container and the casing, let's dive into the architecture of the four functional chambers themselves. Starting with the right atrium, you have to be able to visually and conceptually distinguish its key developmental boundaries. The sinus venorum is the smooth posterior part that receives the great veins. The rough anterior wall is made of pectinate muscles, and separating these two is an internal muscular ridge called the crista terminalis. You also have the fossa ovalis, a little thumbprint-sized depression on the interatrial septum, which has major embryological significance as the remnant of the fetal foramen ovalis.
This structural contrast between the right and left ventricles is definitely a lecturer favorite, mainly because it perfectly shows how anatomical form directly follows physiological function. The right ventricle pumps at much lower pressures into the pulmonary system. It contains the septomarginal trabecula, or moderator band, to coordinate papillary muscle contraction. But the left ventricle, it has to pump blood into the high-resistance systemic circulation. To generate that kind of force, its muscular wall has to be structurally 2 to 3 times thicker than the right ventricle.
And speaking of the septa, or the walls between chambers, take careful note of this classic examination trap. Students often mistakenly guess that atrial septal defects are the most common congenital cardiac anomalies. Actually, the correct answer is ventricular septal defects, or VSDs. Because the left ventricle operates at such high pressures, a VSD causes massive left-to-right shunting of blood, leading to severe pulmonary hypertension and rapid cardiac failure. So it's the most common and clinically the most dangerous.
Moving on to Section 4, the power supply, coronary vasculature.
A pump working this hard continuously against high systemic resistance needs a massive, high-volume power supply. So let's talk about the coronary arteries and venous drainage. You really want to memorize these vascular territories. The myocardium is supplied by the right and left coronary arteries, which are the very first branches off the aorta. In an exam, mapping an occluded artery to a specific area of a myocardial infarction is virtually guaranteed. Notice how the left anterior descending, or LAD, supplies the anterior ventricles, the anterior 2/3 of the interventricular septum, and the bundle branches. Meanwhile, the right coronary artery primarily handles the right side, and crucially, the SA and AV nodes.
Breaking down the frequencies of coronary occlusions, the anterior interventricular branch, again the LAD, is the most frequently occluded vessel, causing about 40 to 50% of cases. Because it directly threatens the anterior ventricles and the heart's electrical bundle branches, an LAD infarction is incredibly severe. Next up is the RCA at 30 to 40%, followed by the circumflex branch of the left coronary artery, which accounts for about 15 to 20%.
Now what goes in must come out. While the vast majority of venous blood returns via the coronary sinus, which sits neatly tucked in the posterior atrioventricular groove, you must deeply understand the exceptions. Examiners love exceptions. The anterior cardiac veins uniquely bypass the coronary sinus system altogether, crossing the anterior groove to drain directly into the right atrium. Let's wrap things up with Section 5, End of Lesson Review.
Let's lock in everything we've covered with a rapid, active recall session to make sure you're totally exam ready. Here are 5 high-yield facts integrating anatomy, physiology, and clinical practice. First, the transverse thoracic plane at the T4-T5 disc separates the superior and inferior mediastinum. Second, cardiac tamponade restricts diastolic filling, dropping cardiac output and causing Beck's triad. Third, the left ventricle is 2 to 3 times thicker than the right due to high systemic resistance. Fourth, ventricular septal defects are the most common congenital defects. And fifth, the LAD artery is the most frequent site of coronary occlusion.
I want to leave you with one final, vital, clinical reasoning question to really chew on. Based on the thoracic boundaries we explored today, what precise structural feature uniquely exposes the bare area of the pericardium, allowing you to perform a life-saving pericardiocentesis without piercing a lung? Connecting abstract anatomy directly to emergency patient care, that's the mark of a true health professional. Thank you so much for joining me in this explainer, and best of luck with your revision.